Assalamualaikum and hi everyone. My name is Alia.
My name is Alia.
Today we will present about the Wolff-Parkinson-White disease.
Okay, today I will explain about a disease that called Wolff-Parkinson-White syndrome under anti-arrhythmic drugs. Okay, first I will explain about the definition. It's an extra electrical pathway between your heart's upper and lower chambers that causes a rapid heartbeat. Next, the symptoms. Symptoms are divided into three, which are common symptoms. The common symptoms include the sensation of rapid, fluttering or pounding, second heartbeat, palpitations, third dizziness or lightheadedness, fourth shortness of breath, fainting, fatigue and anxiety. Second is the symptoms in more serious cases. First is chest pain, which are angina. Second, chest tightness. Thirdly is difficulty breathing and also fainting. And lastly is symptoms in infants, which are ashen color, restlessness or irritability, rapid breathing and poor eating. Okay. Then the causes. First, the abnormal gene. The second is the abnormal electrical system. An abnormal electrical system is an extra electrical pathway that connects the atria and ventricles, that allowing the electrical impulse to bypass the AV node. And then when the electrical impulse uses this pathway through the heart, the ventricles are activated too early. And then the last causes is a congenital heart disease such as Epstein's anomaly.
Okay, next, I will explain about the treatment of WPW disease. The first treatment is catheter ablation. It destroys the extra electrical pathway in your heart. It uses a tiny catheter is inserted into an artery in your groin and treats it up into your heart. Okay, the next treatment is electrical cardioversion. This treatment apply an electrical shock to the heart. It can restore normal rhythm. Okay, next, anti-arrhythmic drugs. There are two types of drugs used in this disease, adenosine and amiodarone. Okay, next, the side effect of anti-arrhythmic drugs. When adenosine is used, it will cause flushing, chest discomfort, shortness of breath, abdominal pain or discomfort, and lightheadedness. Okay, next, amiodarone. Amiodarone will cause feeling dizzy or tired, nausea, vomiting, stomach pain, constipation, loss of appetite, and sleep problems like insomnia. Okay, the contraindication of WPW disease. When the patient is given digoxin or non-dihydropyridine calcium channel blockers, example verapamil and diltiazem, it will cause increase the ventricular rate and cause ventricular fibrillation. Okay, next, if the patient is given adenosine, it should not be used for pre-excited atrial fibrillation (AF). The efficacy in reducing the risk of accelerated conduction of AF in WPW patients is unclear. Thank you.
Assalamualaikum dan salam sejahtera. My name is Nur Ifraizani binti Sabri. Today I will present about the significance of the drug involving the anti-arrhythmic drug agents. Anti-arrhythmic drug classified into 4 classes, which is class 1, class 2 and class 3 and class 4. Class 1, it will divide into 3 parts, which is class 1A, class 1B and class 1C. Class 1A, it has 3 drugs, quinidine, procanamide and disopyramide. For the quinidine, interaction with the drug either it induce or inhibit. Defining when the level of quinidine is low, Rifampin will help to accelerate the metabolism of the quinidine, so it will increase the quinidine level. It means it will overcome the dose of the quinidine. For the inhibit, cimetidine will help to inhibit the quinidine level when it is reach high level. When the quinidine level is high, cimetidine will help to inhibit its metabolism. So the quinidine level will reduce. It will monitor the quinidine level. For the class 1B, we have 3 drugs, lidocaine, mexiletine, and phenytoin. For the mexiletine, when the level of the mexiletine is increased, it will interact with the quinidine. The mechanism of the quinidine is to inhibit the mexiletine metabolism, so it will reduce the mexiletine dose and avoid the combination. When the mexiletine level is reduced, it will interact with rifampin, because mechanism of the rifampin is to accelerate the mexiletine metabolism, so it will increase the mexiletine dose and avoid combinations.
My name is Muhammad Bukhari bin Abdul Rahim. I will continue by explaining about anti-arrhythmic drugs for the class 2, class 3, and class 4. The anti-arrhythmic drug class 2, which is beta receptor blockers. For example of the drug is esmolol, propanolol, metoprolol. Basically, this drug is less interaction with other drugs. The class 3 is the drug that react to the K+ channel blocker. The example of the drug is amiodarone, dronedarone, sotalol. It may have the interaction to the drugs. For example, is digoxin, flecainide, lidocaine, quinine, simvastatin, cyclosporine, phenytoin, and warfarin. For this example, when the patient consumes the amiodarone, it will cause the increased level of interacting drugs. Then, at the same time, when the patient consumes the least of this drug, it will cause the decrease in metabolism of the drugs by amiodarone. Then, to overcome this, we need to monitor and adjust the dose of the drugs that have been given. Next, it also has the interaction drugs to the drugs class 1A and class 1C. The effect will cause the pro-arrhythmic effect, which will cause the additive in QT interval prolongation. To overcome this, we need to avoid combination consumption of these drugs and monitor the QT interval. Then, it also have the interaction with the calcium channel blockers and beta blockers, which when the consumption of amiodarone will cause bradycardia, and when consumption and at the same time when the patient consumes the calcium channel blockers and beta blockers, will cause additive decrease of conduction, which can then to overcome this, we need to monitor the blood pressure, pulse rate, and avoid the combination when consumption of those drugs. The last one is the class 4, which is the drugs that react to the calcium 2+ channel blocker. The example of the drug is verapamil and diazepam. When the patient consumes these drugs, it will cause the bradycardia, heart block, and heart failure. Then at the same time, when the patient consumes the beta blocker drugs, it will cause the additive effect on myocardial contractility and conduction, which we need to avoid by combination the verapamil, diazepam with the beta blockers drugs. Then verapamil itself also cause the hypotension, which is when the patient also consume the quinidine, it will cause additive alpha blockade. Then to overcome this, use verapamil consciously. Then diazepam and verapamil itself also cause the increased cyclosporine level. Then when the patient consumes the cyclosporine, it will cause the inhibition of cyclosporine metabolism. Then, to overcome this, decrease the cyclosporine dose and monitor the serum levels. Then the last one, verapamil also causes the increase in phenytoin level. When the patient consumes the phenytoin during the consumption of the verapamil, it will cause the inhibition of phenytoin metabolism. Then to overcome this, decrease the dose and monitor the level. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. I'm very good morning, Abdullah. Hi, I'm Mr. S. Today I would like to talk about the antirhythmic drugs that are not under Vaughan-Williams classification. First and foremost is digoxin. Digoxin is an inotropic agent which acts as cardiac glycoside. Digoxin also inhibits the sodium-potassium ATPase pump in cardiac muscle cells to alter their function so that sodium cannot be extruded. Then, intracellular sodium concentration will increases. Increased sodium concentration will also decrease the AV nodal conduction, which lead to parasympathomimetic effect such as negative chronotropic effect. Then, digoxin also decrease the ventricular rate in atrial flutter and fibrillation. Secondly, adenosine has a negative inotropic effect in cardiac atrial fibrillation, which means direct negative inotropic effect. This effect is probably due to an activation of potassium outward current, which shortens the action potential duration and hence reduce the force of contraction. In addition, adenosine has negative chronotropic actions and prolongs AV conduction by an activation of potassium channels or an inhibition of the slow Ca2 plus inward current by AV node. Cardiac bradyarthritis in hypoxia have been attributed to an increased formation and release of adenosine. Lastly is atropine. Atropine is a muscarinic receptor antagonist that is used to inhibit the effects of excessive vagal activation on the heart, which is manifested as sinus bradycardia and AV nodal block. Therefore, atropine can temporarily revert sinus bradycardia to normal sinus rhythm and reverse AV nodal blocks by removing vagal influence. Muscarinic receptor antagonists bind to these muscarinic receptors, thereby preventing acetylcholine from binding to and activating the receptor. By blocking the actions of acetylcholine, muscarinic receptor antagonists very effectively block the effects of vagal nerve activity on the heart. By doing so, they will increase heart rate and conduction velocity. That's all from me, my Mr. S. See you later.